Attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse. I am Dr. Anthony Pellegrino from ChiroEdge, and welcome to this week's episode of the Chiropractic Research Breakdown, where each week we break down the most relevant chiropractic science and philosophy to empower you with the ammo and certainty necessary to change your community from the inside out. All right, attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse. I'm Dr. Anthony Pellegrino from ChiroEdge, and welcome to another episode of the Chiropractic Research Breakdown, where we break down the most relevant chiropractic science and philosophy to empower you with the ammo and certainty necessary to change your community from the inside out. I am happy to be joined by Dr. Mike Marinus today, who we're going to be discussing a really important question that he posed in a recent research article that was published in the Journal of Clinical Chiropractic Pediatrics. And the clinical question that he sought to answer in this review of literature was, is positional plagiocephaly associated with neurodevelopmental delay in infants and toddlers? So if you are a chiropractor who sees kids with neurodevelopmental challenges, then you want to listen to this. And if you're not that chiropractor, I don't know why you're listening to this, because this is what we talk about all the time. So I'm really excited to go ahead and dive into this with you, Doc. Real quick before we get in, if you guys like this kind of information, as you know, one of the things we do is we take this type of info and make it into patient news, education newsletters for you with your information, with your brand. Go check out ChiroEdgeMedia.com if you guys want that for your practice. Other than that, Dr. Marinus, thank you so much for joining me today.
It's an absolute pleasure. I've been looking forward to this for a while. Really passionate about pediatrics, really passionate about putting research out there from a chiropractic standpoint in pediatrics. It's one of the things that we know that we can do a lot better on. So I think, anything that has to do with pediatrics and research, I'm in, man.
I love it. Now, that is the statement of the day for me. Anything that has to do with pediatrics and research, I'm in. You just recently, we were just chatting, you completed at AECC. You're from South Africa, but you just completed your master's over there. I had never heard of that master's degree before. Tell me about what the degree you just finished was.
Yeah, so, I qualified in South Africa in 2005 as a chiropractor, and then I saw kids for about 10 years. And then I thought to myself, I need to, if I'm going to get into this, I think I need to get into the teaching and research side. So I looked at, for me, what would be the best course or best degree that I can go and do. And through all of my research, Anglo-European Chiropractic College had a fantastic master's course put together, which was 3 years, which saw me doing a lot of travel to the UK, saw me meeting a lot of people, which ended up in traveling to the Kids Summit in Chicago, to meeting a whole bunch of people through that. And the degree itself was 3 years. It was fantastic, culminated in a master's, which I did on my practice, which I found invariably valuable for me. And that's where I sit now. Just finished it up this year. So, I'm now in a position to start using that information and put together some papers and hopefully add to the pot of information that we have as chiropractors that see kids.
I love it. Well, you're going to have me hitting you up if you keep publishing stuff like this. Now, the name of the paper, guys, is there an effect of positional plagiocephaly on neurodevelopmental delay in infants and toddlers? Is this something that you kind of published through the masters, or is this just something you did on your own?
Yeah, absolutely. So this was one of my modules that I put forward for the masters. It was one of the modules I had to do. And it was something that I've been working with speaking a lot with a chiropractor in the UK, Steve Williams, who does a lot of work on plagiocephaly. A couple of the other guys I was studying with were really into plagiocephaly. I was seeing a lot of it in my practice because that's the age group that I see a lot of is under 6 months. And I thought to myself, especially like that paper starts off, it's exactly what happened. I had a mom who came in, and she's an OT, and she came in and went, look at what is happening to my child's head. But being an OT, she was less worried about aesthetics as she was about what kind of delay was going to be associated with that. And I found myself in that horrible clinical position of going, I can't tell you because I don't know. But then what I did, to be as honest as possible, is I said, let me go and find out. And that was part of the module. And I've actually done a lot of work with her forwards from that in this kind of field, which has been wonderful. So not only was it a chance to put together some research, but it was also a chance to get hold of someone outside the profession, explain to them what we do, and have her on board with with becoming part of my tribe, which is fantastic.
I love it. I love it. Now, the review was specifically on non-synesthetic skull asymmetry, correct? Let's go into it, man. Tell me what you found.
Okay, so first of all, I suppose just to break it down a little bit, plagiocephaly comes in two flavors. You come in craniosynostosis, which is where you get an early fusion of those lines between the cranial bones of those sutures. That it generally ends up being surgical cases, or at least managed by having imaging and that kind of thing to see what's happening. What I focused on was the non-synostotic. So basically what we're talking about is there's no morphological change in the sutures. The bones are fine, the sutures are fine, but because there's been an external force that's been applied to those particular bones, they are starting to respond to that force. And the interesting part is when you break down how those top parts of the cranial bones are actually formed. Because the base of the cranium, those bones form in a cartilage matrix. But the bones that come up the side, so from here up to the top, those bones form inside a membrane. And it's really important that they do that because those top bones of your skull have to be so malleable so as to be able to allow you through the birth canal, but also to allow areas like the cerebellum to double in size over the first 7 months. So it's really important that those bones are soft. The problem is now what we have is those soft bones having themselves applied to the surface continually, and they start to flatten. And if they start to flatten, then the rest of the head takes on morphologically a different shape.
Right. Now, we started with, you mentioned like number one, or one of the major factors contributing to this is the Back to Sleep campaign, which started in 92, which it's effective for what it was. It worked, right? Like
80%, it brought it down. And one of the weirdest things is still, we don't know why. That is one of the craziest things. We moved kids onto their backs, and that statistic happened. And we started, and 80% of the kids, 80% less of these SIDS cases. We still to today don't know why lying on your back decreases SIDS. We have no idea. We have a lot of hypotheses around why that happened, but we have no idea. Because the thing is, SIDS is not about getting something in front of your face. That is called ASSB. That's a whole other problem.
Really?
SIDS itself is when kids just stop breathing. They stop, they don't get a gasp reflex, and they just stop. And we think it might have something to do with the position that they lie in when they're on their stomach. So it might be that extension and that effect on the blood supply to the brainstem. Mm-hmm. Because also, very interestingly, when you do autopsies on kids that have died of SIDS, they all have these pre-existing lesions to the brainstem. So it's not the first time that they've had blood supply cut off to the brainstem. We don't know why, but we know that when you lie them on their back, the chance of SIDS goes down dramatically. So from 92, that became the thing. We lay all kids on their back, and because it was safe, everyone did it. The problem is, and an unforeseen thing, was that now you had this unremitting force on the occipits of babies continually. And especially where you had a baby, let's say, out of a Caesar birth or something where they had a little bit of a rotation restriction. Now you have a kid who only looks to the right-hand side, lying down, constantly putting pressure on that right bone. And that starts to flatten out, which means that there are other morphological changes in the front of the skull as well. You start to get differences in shapes of eyes, the ears start to go off kilter, and you end up with this. I think the stat I read today was at least 50% of kids in the Western world have some degree of morphological change to their skull.
About
that's
50%.
Aberrant to what would be considered.
That's
50%
wild.
have some change.
Right.
It's crazy.
Right. Now, Doc, it's almost like, I'm just gonna circle around. It's almost like you just told me that the position of the spine, possibly alignment, I don't know, we don't have to go there, actually has influence on the nervous system or the brain. It almost kind of sounds like that. I don't know. That's something maybe chiropractors have been saying for a while, right?
So it's one of those things that what we can say with certainty, it is biologically plausible. It is biologically plausible that having that position on the nervous system changes a certain amount of blood supply up into the brainstem, which then changes brainstem function. That changes brainstem function to the point that it shuts down.
Right. And we've seen that in adults on like You've seen cervical curve, cervical kyphosis, cervical lordosis on functional MRI, which we've done a review with. That's recently a CBP article that comes out. You've got cerebrospinal fluid changes with upright MRI from Demadian and Scott Rosa. So we have good beginnings of this research base with adults. Is really important when we look at, and obviously you being a pediatric specialist. So I love having people like you who are into specifically pediatric research, which is more difficult, especially more difficult to get funded. The last sentence of your article was, "This was not funded," so I have no, conflict of interest. But that's something that's. I mean, it's just really, really important to understand there. So we've got the difference between the non-synesthetic and the synesthetic there. We got the morphological changes happening. Back to sleep worked, reduced incidence of SIDS for whatever reason. But now we're seeing that because of these morphological changes in the position of the cranium, we're seeing this relate to, you were exploring neurodevelopmental challenges, neurodevelopmental delays. So in terms of what you found on that, what kind of changes did you see come out?
Okay, so the first thing is, for as long as the research has been going, it's the majority of authors have said it's simply aesthetically different. So they've said the head shape changes, but it's aesthetics, and we're going to leave it because that's what it is. Then you got a couple of guys starting to say, I don't think that's it completely true, because we're starting to see certain things connect with plagiocephaly. Like one of those things is torticollis. So we're starting to see something like a torticollis, especially when you have a proper plagiocephaly, which is like a parallelogram head, which is that one side at the back flattens out, the one side of the front comes forward. Especially when you have that, like 50% of those are, at least one of the researchers I looked, are linked to this torticollis happening. And so they start saying, but hang on a second, there's a limitation to movement there. So there's now a physical limitation. So what is that going to do to the motor development? Because that is definitely going to change. If that kid's always looking off to the right, how are they going to roll to the left? Those kind of things. How are their developmental steps going to be changed by this? So that was number one. Number two, they started looking at, wow, maybe if the actual parameters of the brain and the parenchyma of the brain is actually, its size and shape has started to be changed, is that going to have an effect on cognition? Is it going to have an effect on language? And then they started to put a lot of these things together, and that's when the research started to come out. And interestingly, it started to come out because plagiocephaly became the number one reason that babies were seeing craniofacial surgeons. And the craniofacial surgeons were going, this is wild, because these kids don't have another problem. This is a problem that it's almost being caused by their environment. And through so many of them going through that kind of channel, you start to get people going, hang on, if this is happening, I wonder what kind of effect this is happening with the kids later. So then there was a whole slew of research that came out looking at cognitive change, looking at motor response, and looking at language.
That's amazing.
So yeah, that's where we find ourselves at the moment. So we've got a lot. So I was able to find, I think it was about 10 or 11 papers that fitted what I was looking at. So to be clear, I wanted no children with any craniosynostosis, because that's a completely different kettle of fish. Something different's going on, and we're not looking at that. So I wanted researchers that were looking at plagiocephaly, but it was positional. I wanted research papers that were looking at, that were using a method of working out what the motor responses were. So I wanted a valid questionnaire that was being used, or a validated implement, to look at what was happening with their cognitive effects and those kind of things. So I found more than I thought I was going to find, and the results were fascinating. They really were, because they went up and down, and some of the papers had massive sample sizes. And so when I put everything together, I really had to take those into account and weigh them slightly differently. And like we were talking about before we started, measurements are all over the place. So to say a child has plagiocephaly is not one thing. It is such a shade of gray. So we had some that were just taking like a manual measurement. So we had some that were taking a measurement from the occiput to one ear, and from the occiput across to the other ear, and taking that measurement. We had guys measuring with calipers from front to back and back to front. We had guys doing 3D reconstructions on, like, computerized 3D reconstructions. There was the Hutchinsons, which did something called a heads up. And the problem is, the fancier you get, the more one would hope the more reliable the information becomes. But what ends up happening is it becomes something that you and I now can't do in practice. So it becomes almost useless to us because I can't get a heads-up display unit in my practice. I'm never gonna be able to afford that. Not even the guys doing the research could afford it. They had to go somewhere to put the thing together, But interestingly, like we were talking about before we started, we had one or two papers that looked at how valid all of those different mechanisms were, and they didn't see a massive change in validity when you were using these high-impact, high-tech, very expensive things versus using a measuring tape or using a pair of calipers. So it made the review that I put together made it a little bit tricky because everyone was using something different. But basically what I said is, if it's a valid method that you're using, I'll take it. So what we found was overwhelmingly motor change. There is overwhelmingly a change to child's motor function when they have plagiocephaly. That change is a lot more seen in the first couple of months, and they start to catch up slightly later. In the cognitive change, which was seen quite a bit, that also by 12 months, they were pretty much caught up. But the cognitive change was not as visible and wasn't as shown up as the motor change. That was one of the most important. A very interesting paper that was in the middle was by an author called Fowler. And what they talked about was that they talked about tone. So they said, because what one would assume is that it's kind of almost low-tone kids that are lying there and don't have the ability to be able to lift their head up and turn it, so they're always on one side. But what Fowler found was it's a change in tone that leads you to this plagiocephaly. So it's not about you having just low tone and just kind of lying there. Also kids that have high tone, so big extensions. So you get kids that are lying there and thrusting themselves into extension. So I found that really interesting because it was anything away from normal ended with this aberration.
Really?
Yeah, so it was. I found that fascinating because I had always assumed that it was a kid that was stuck in that position and couldn't move out. I hadn't thought maybe it was a child that had a motor response that was really aggressive in that position. It was holding it in that position. So I found that fascinating.
Yeah, my wheels are turning, and I'm just thinking about this mechanism, and I'm just, I'm
kind of go all over the place as well.
There's so much to process with that. So this is definitely going to be something that I go back and listen to a couple times, just because, even thinking about it. And one thing that I loved that when you were kind of going through that you mentioned was of the, I just read it recently. So you said there were 12 articles that you had found. Something you commented on that I thought was really interesting is that I think it was like you said 50% said that there was no change and 50 said that there was. And that all the ones that said that there weren't neurodevelopmental issues were all really small sample sizes. And all the ones that had big sample sizes said, we there is a change. So it's so amazing to me to see when we come to thinking about things that are different than medicine and different than the mainstream and different than what's affected. One of the major retorts that we get from people who don't believe in the neurological position is, oh, well, like, what's your sample size, right? Is this a real research article, or did you just do something with 5 people and it showed up? And you're going ahead and saying, hey, your own research, what you've looked at says in your larger studies that there is neurodevelopmental changes. Maybe that's something we should pay attention to.
Yeah, absolutely. That was a really, really interesting point, is that just because there's a paper out there that says something, that doesn't mean you straight out believe it. You have to go into that paper, you have to look at it, you have to look at the parameters, because research is not all research. You get bad research and you get phenomenal research. And just because it is up there on PubMed doesn't mean that you just pull it off and you take it as gospel and you go and show it to all your people as this has proved my position. Not only do you have a good look at it, because you might end up, a lot of egg on your face.
Yeah.
Interestingly, there's another point that goes in just with that, with what you were talking about now. The other one that's interesting is that a lot of the research didn't have control groups.
Okay.
So a lot of them were just looking at what's happening with the kids that I'm looking at. So without a control group, you don't quite know where you're going. And what they did, instead of having a control group, is they said, well, here's the normative data.
Right.
So instead of doing a control group, I'm going to do normative data. Here's the kicker. There's something called the cohort effect that kicks in there.
Uh-huh.
because normative data comes from a place at a time. And the people that you got that normative data off may have had a different situation
Right.
to the people you're looking at now. And when I looked further into it, a lot of the way that they used questionnaires were all put together with normative data before 1992.
Wow. Okay. Yeah, that's fascinating.
So that can't count as much as normative data taken after 92, because you're talking about kids that were sleeping on their stomach.
Right.
You're not talking about kids that were part of the Back to Sleep campaign. So that as well, it took a bit of preference in my mind when I was looking at putting it together.
Yeah. Yeah. It's like for anybody who didn't get the point there, would be looking at, let's say you're trying to figure out changes from radiation and comparing it to normative data of Chernobyl and saying, oh, well, there's no change in this data because the baseline, is the same amount as the baseline. And it's like, well, the baseline had a nuclear event. So that you have to have different, it has to be different. So that's huge. That's something really big to understand. I love when you think about it, the way that's the whole reason that this whole show exists, right? Like we take the research, we break it down, what's good, what's bad. We've had tons of different examples, like high blood pressure, for example. Read studies that say there's no autonomic change with chiropractic. And you find out that they're just randomly slapping somebody on the side of the neck. There's no specificity whatsoever. It's like, well, is that really chiropractic or is that just spinal manipulation? I don't know if you listen to On Purpose with Pat Gentempo and Christopher Kent. I love it. They reviewed a book, I think it was a book that was written by a medical researcher who commented on the fact, and I'm going to butcher the exact numbers here, but I'll try to find it if you're interested. It was like 85% of medical articles are either since 1985, are either retracted or proven false. Like 85% of what we have learned in the last 20 years is we think it's different now than it is today. So it's like even the information that we have today, even like this conversation, who knows if it really is true, if it's just true on the amount of knowledge and understanding that we have today. But we have to view everything through that lens. And when we get stuck in this dogma of science and saying, hey, if the data says this one thing, then that's 100% it forever, we have really pigeonholed ourselves and we'll stop to advance as a society. And
you're so right. The moment you start to go, this is exactly how it is, all that says to me is that's the moment you've stopped looking.
Right.
And things will change. We know things change. We know that as more information comes in, the picture is going to become clearer. We start to see more and more of the elephant as time goes on, and we start to understand more and more of how that elephant fits together. At the moment, we might just have a trunk and a toe, but we do our best with the foresight of going, this is what we know, but not with the arrogance of going, this is what is known. This is what we know right now. And then to do the best for our patients, we have to go, I'm going to give you treatment based on the best that I know right at the moment.
Okay, I love it. Thank you. This is fun. You're an expert now in all things musculoskeletal in kids, right? All things plagiocephaly. You're just the pinnacle. So I don't know if you knew that, but now as this guest on the show, officially you are. What do you think is important for, whether it's in education or clinically, for any chiropractor who's listening who's going to go back to their office today and take care of a bunch of kids? What type of stuff can we either use for our communication with our parents of our children, or what can we do or think, or how can we change how we view things clinically, whether it's our evaluations or whether it's through our actual care that we render? What type of information do you think is really important for a chiropractor to take away?
Okay. So I think the one part of that I'll tackle is what can you take tomorrow into your practice that you can talk to your parents about? And I think the first part is exactly what we've been talking about now. There are three parts that you really want to get into. The first part is listen to them. That is the first part, because we, a lot of the time, almost have an agenda that we're trying to push. And that agenda may very well not line up with that parent's agenda. So the first thing is to sit down and say, what is wrong? How can I help you? And then I can start to move from there. So the first part is to get that the parent and the child's perspective on what they're looking for and where can I fit into that for you. The second part is to be able to go, my clinical experience says X, Y, and Z. And don't be afraid of saying my clinical experience tells me that this is how long this condition will take. This is what's happening with this condition, and this is how I see myself helping your child in this condition. That is part of evidence-based practice, is your clinical ideas, what you formulated over time. Then you can also bring in the evidence, and you can say, look, the evidence says. So I'll give you a nice idea. If I have someone who comes in with a child that's crying, I can say to them, at the level of systematic review, which they're not going to understand, but I can say at one of the highest levels of evidence that we have, it shows that on average, I will bring down your child's crying by an hour and 20 minutes a day. Are you happy with that? Yeah? Yeah, I'm really happy with that. I'm not trying to tell them I'm going to do that. I've started off saying that is what the research says I can do. And then in my clinical experience, I can say, it's going to take me this long because I know through doing my master's, it's going to take me 11 days. I can tell you that down the line. And then go, how much is that going to help you? Is that what you need help with? Yes, that's what you need help with. Fantastic. So I think clear-cut communication with people, I think a lot of the time gets rid of the holes we kind of dig for ourselves with people, because I know I do this a lot. So people will come in and I have an idea in my head of how I want to help that kid. I see that the kid is listening to the side and I want to tell them all about neurological function. I want to tell them all about writing reflexes. I want to talk to them about primitive reflexes. I want to talk about all the different things. And the thing is to be able to go, hold that back. I know all of that, but it doesn't help to dump that on them right now. Why are you here? Let's get on board with each other while we're here. And then through time go, look, this reflex is really important as well. That's really important as well. Let's make sure that there's the future of this child is that they're going to grow up strong, straight, and healthy, But that would probably be the biggest pill that I've taken because I'm a stupid guy. So that's the pill that's taken me the longest to realize, is to be able to go, my clinical experience does count. So does their preference, because sometimes we steamroll them with what we want. And then the last thing being, if you can back up what you say with evidence, they can go to any other practitioner in the world and they can say, yeah, but he said that. And you can go, yes, of course I said that, because that's what it says right here.
Now, I know I'm just real quick, we're going to continue down this path because that was awesome. But I know I'm going to get emails later today.
Yeah.
The hour, 20 minutes a day for crying. Is that, I'd never seen that. Is that a real number?
That is in a systematic review, not done by a chiropractor, done by an author called Can. I will send it to you.
Yeah, please.
So you can put it down into your notes if you give it to people.
Yeah.
What it was, they looked at manual therapy and crying, and it was based on another one that I'll give you as well, so 2012 from a person, another systematic review with meta-analysis called Dobson. Both of them found over an hour's worth of crying decrease. And I know that even with Heidi Harvick's new stuff, she brings these two pieces of research in as well.
Yeah.
Those are, first of all, those are not chiropractic authors. They have taken manual therapy. And if you look at the CANS one, out of the 6 RCTs they looked at, 5 were chiropractic and 1 was osteopathic. And they came out with the fact that an hour, 20 minutes on average, your baby will cry less. And then they had to caveat it at the end. And then they said, but we don't know if that's going to make a difference to parents. Which is then where one of my mentors at ACC, Joyce Miller.
Yeah.
So then she did that study that came out end of last year with over 2,000 kids. And she asked parents, do you feel that chiropractic care has made a difference and the lack of crying has made a difference? And of course, over 90% of the people said yes. So that question from Kansas asked and answered. And you can put that wherever you want to, because it's out of a systematic review meta-analysis. We get them to cry over an hour less a day.
I love that. I'm sorry to get sidetracked on that. You said that. And I just was like, excuse me, I'm going to talk to people about this. Like it's evening for you. I think you said it's 5:15, or I guess it's 5:45 for you. It's 10:45, man. I got practice members in a couple hours. So I'm going to implement today. All right. I'm going to do that today. That's awesome.
And the thing is, we always get taken down for saying, you're saying things without basis. It's there. It is there. We just have to pick and choose the things that we say, because there are things that are in stone at the moment. Because, I mean, that level of analysis, that level of review, doesn't get higher. I'm not talking about a case history series, or I'm not talking about a retrospective review of like 4 cases. We're talking about 6 RCTs that they put together, and then they actually applied, higher science to be able to find out what the actual outcome was.
Yeah. Yeah. So why would a parent bring their kids to see a chiropractor? proper growth and development, strong, healthy, straight, less crying by an average an hour. Like it just makes so much sense.
Yeah.
Thank you. If nothing else, I hope people got something from that.
This is always my thing. When I talk to parents coming in, we go, you only get that first 3 months once. If you can bring down the amount of crying, which means what you're doing in effect is on average, you're increasing your bonding time by over an hour a day with your child. Are you happy with that? I mean, who's not happy to spend another healthy, happy hour with their baby? Because it doesn't come around again. It only comes around the one time.
I love that. Well, thank you so much. And please send me that article.
Absolutely.
Because I'm definitely going to read that later today and show it to my wife because she's smarter than me. Yeah, it's going to be great. She'll say, all right, so this is how you
as well.
Yeah. She'll take, she's smarter than me, both not only research wise, but she'll also read something science and be like, okay, now this is how we communicate with real people. Okay. You can't, no, that's why I have to have this podcast so I can talk to you. We can use big words like plagiocephaly. And she's like, this is how we talk to people, like actual people, not you. So thank you. So that was the education piece. Now that we went there, clinically, whether it's we're changing up the way that we look at measurements or how we adjust or assess, what kind of stuff should we take for that?
Okay. So I in my practice, I use a set of calipers because it is easy and it's cheap and it's as reliable as everything else according to the data. And my set of calipers allows me to take different plagiocephaly measurements. So you get a brachycephaly, which is a short head front to back. Think of a Boston Terrier. They call them brachycephaly dogs. So it's that short back to front. You also end up getting something called scaphocephaly, which is long back to front. And when you have, I can't remember the make of them, but either way, they're plagiocephaly calipers. You can measure out a brachycephaly or you can measure out a normal plagiocephaly. And what's nice with those is then you can actually have numbers that you can put to those and go, this is the number where we have a problem. This is the number where we're safe and we can carry on working. So when I work with other professionals, I can also go, look, the cranial index is X amount. So that's why I'm referring on, because it's getting worse and it's not. And also, if you don't measure something, how do you know what effect you're having on it? So that's the first one. I use a pair of calipers because I find it fantastically, it works really well. The technique that I use, I know I talked about Steve Williams earlier on. He's a chiro in the UK. He teaches a lot of cranio adjusting, which is super, super light. And it has to do with getting the cranial bones to release slightly to get the tension of the ligaments that sit inside the skull to be able to release as well. It's a whole story to get cranial adjustments going. I'm sure ICPA guys will actually, I learned a little bit of cranial from Martin Rosen as well, who used to with ICPA.
Right, and actually, I'm going to his. He has a three seminar series.
The one in Boston.
I'm going to the one in Boston. I haven't signed up yet, but it's on my 2020 list.
You have to go. I saw him in Amsterdam last year. He is incredible man.
I took his ICPA seminar while I was in school before I learned SOT. And it was like, it wasn't a fire hose. It was like I got beat in the face with a shovel. I needed a cranial adjustment after that. It was crazy.
I was talking New Yorker as well.
I love it. Now I'm from New Jersey, so we're okay with that. We got that, but that's great. So you said Steve Williams. I haven't heard of Dr. Williams, so I'm going to look him up as well. You said he's based in the UK.
Look him up. He does a lot of seminar teaching as well. Fantastic guy. I've learned a stack load practically from him. He and Martin actually they taught at the Kids Summit in Chicago together.
Awesome.
That I think is the mistake I used to make. Is plagiocephaly is not a skull problem; it's a baby problem. It's a baby problem from the bottom to the top, and you have to look at everything because you can have a tight psoas that's pulling a baby into a curve, which means that every time they lie down, they're looking off to the one side. If you miss that, you can keep fixing all the stuff at the top that looks sexy and wonderful to fix. But if you're not looking at other pieces of the puzzle, you might not fix everything. So when you look at a plagiocephaly, please, you're not looking from the head up. You're looking from the top of the head right the way down to see what's happening. Because again, to keep in mind, plagiocephaly is what we call a packaging disorder. which doesn't sound great. It sounds like something that had happened in Amazon. And I suppose it is the same kind of thing. It's a packaging thing, because a lot of the time it starts off with baby's head forced against the internal rim of mom's pelvis or forced up against the lumbosacral spine. So a lot of the time that is where it starts. So if there are those packaging problems, we have to look at like equinovarus into the ankle. You have to look at a possible hip dysplasia. You have to look at torticollis. You have to look at all the other things that are classified as those as well. So it's a full check when it's plagiocephaly. You're not just looking from the top up to get the bones to start working. And I also find that if I can get a torticollis out the way, those things just disappear by themselves. But a lot of it is, once we've done with the adjusting and once we're done with the mechanical side of it, there is so much chiropractic that is in the advice that we need to give moms and dads. It's frightening. There's so much. And weirdly, the most of it that I got was, I suppose you don't know, I run a podcast as well, weirdly, which is very small. But I interviewed a German pediatric researcher called Renz Polster once.
Okay.
Because he did a paper on plagiocephaly and the Western industrialized environment and how that affects plagiocephaly. And he talks about how whacked out is this? He talks about when babies sleep on their backs, which is what we do with back to sleep, they have this unremitting pressure on the back. What he says is naturally what should happen is co-sleeping. Now, be that same surface or a surface next to it, it's fine. But in a co-sleeping environment, what we know is that babies will readjust their positioning during sleep a lot more because they stay more in light sleep than they do in deep sleep. And that almost takes away that factor of supine sleep. It's crazy to be able to say to moms, if you're closer to your baby, chances are they're going to stay in a more light sleep and they're going to have more repositioning. So chances are you'll take that away. Think as well about the amount of time babies spend in car chairs. That also has to do with pressure on the back of the head. So we're talking to moms about put babies in slings, leave your car chair in the car, rather take them out and hold them, put them in a sling, do something else with them that doesn't have consistent pressure at the back of the head. Vitamin D, oh my goodness, think about, kids that don't have vitamin D, the bone gets softer and softer and softer. You also want to talk to them about, just about anything. Like we were talking about now, traveling, you want to talk to them about being able to play with their kids. Tummy time. Oh my goodness. That is one of the biggest problems that's come out of back to sleep, is they actually had to change the name, believe it or not, from back to sleep and tummy to play. Because what people started to think was, well, babies just must lie on their backs and live on their backs forever. They've actually had to add in and tummy to play, because one of the things we know is that if you have good tummy time and you have good extension muscles, all of that musculature that attaches to the back of the occiput starts to put attractive force onto those bones at the back and starts to fix that up again. So there is so much information that we as chiropractors are just primed to be able to give parents that they're not going to get anywhere else, because no one else is looking at this, because everyone else is going, they'll grow hair and they'll be fine. And then you have to go, well, what do you mean by fine? Because this is my child. I want it to be the best. Right. I want them to reach the biggest expression that they can reach. I didn't have them to have fine. If I have the resources and I have the time, I'm going to do everything that I can. And if we can be in that position to go, you know what you can do? A, B, C, all the way down to Z. These are the things you can do that this will allow your child to grow and function as optimally as they can. I mean, why would you not want to do that?
I love it. I'm fired up to go serve some people today. That's great.
Me too. My people are all asleep now.
Well, hey, thank you so much for, first of all, I need the name of your podcast because we got to let people are going to want to listen to it. So what's the name of your podcast? I put it in the comments.
It's called Connected Pediatrics.
Connected Pediatrics. All right. I'm going to put it in the, it's on iTunes, nice and easy.
Yeah. But you got to spell it with pediatrics is PAE because it's the across the pond.
Yeah.
We just add in letters that don't make sense.
Yeah, it's all right. It's okay. It's a what is it called? A diphthong in Latin. But yeah, so thank you so much for joining me here today. Any parting words of wisdom, anything you want to leave, anything we didn't cover that you want to jump into?
Yeah, I think one of the things I really wanted to get across with the plagiocephaly is that the main sort of conclusion was that it might not be that the flattening of the head is the thing that causes the problem. The flattening of the head might be the outcome of the problem that's causing it. So a lot of the time, it's a motor problem that we, as a profession that works with that, a motor problem that is causing that flattening instead of the flattening causing the problem. So that's something that's really important, is that it might be more correlation than one causing the other. They might be bouncing backwards and forwards with each other. But I think the other thing is, you are bound, if you're a chiropractor and you are seeing children, you are bound to see this. It's not something that's never going to come across your plate. This is not something that's weird or strange. This is something that 50% of the population in industrialized society is dealing with all the time. And one of the things that a parting shot I would definitely give with this, I have had so many experiences where I sit down and I put a kid on my lap and I look down at the top of their head and I see the craziest plagiocephaly. And I look at mom and dad and I say, have you seen what's happening with this head? And they go, what are you talking about? Because keep in mind, parents don't look at the top of their kid's head. Parents look at their kid's face. So a lot of the time, you might be the only person that's picked that up. So you are in a prime position to go, look, have a look from the top, see what's happened, see what's happening with the ears, and lead them through. Tell them this is going to cause a problem, being able to turn this way or that way. It's going to have a problem with them being able to show their optimum function. How are they supposed to crawl if they can only look one way or the other? Or, you can go on and on and on about it. But I think the parting shot is, don't be surprised if you find someone where it's there, but the person's not aware of it, because I get it on and on and on.
Yeah, absolutely. Absolutely. It's the same thing with everything. No matter who they're seeing, you can't depend on somebody else. You say, oh, they go to an OT. They're probably primitive reflexes are checked. They probably have this stuff going on. It's like, no, we need to be on top of everything. We need to know. We need to connect. We need to have communication. If they're getting that stuff elsewhere, find out what's going on. See if there's anything you can add in. If it's great, good. Just make those connections. Understand what's going on. So that's really important. Well, Doc, thank you so much for being on here. I'm going to check out the Connected Pediatrics podcast. Pediatrics, spelled that way. Pediatrics, spelled that way after this. Thank you so much for joining me today. Thank you so much for everything you've done for chiropractic and your continued commitment to helping us not only create the evidence, and this is what I love about you, it's not only about creating the evidence that justifies what we do, which is important, but also creating the evidence that improves what we do. Because it's not just about saying, hey, I make this comment, let me get the research that supports this comment, but rather having everything we do be informed by the highest level of certainty and research. And I appreciate your commitment to that. Well, guys, thank you so much for joining me. I know you got some nuggets out. I know you have to listen to this a couple more times because we went through a lot there. Once again, check us out. It's the Chiropractic Research Breakdown Podcast. You can jump on chiroedgemedia.com for more information about getting this kind of stuff in newsletters. Dr. Marinus, I appreciate you jumping on with me today. And guys, go slay some subluxations. I love you all.